Greetings, this is Dr. Tom Dombrowski. The purpose of these Putting It Together videos is not to give you new information that isn't in the other videos, but to show you how you'll use the information in the clinical setting. So first, let's think about what nurses do. And if you were watching a nurse from the outside, why, you'd see the nurse going in, checking on all the patients, and then maybe giving some medications, answering patient requests, answering patient calls, and that sort of thing. But what you won't see necessarily is that nurse is constantly doing assessment, because most of the assessment is going on inside of his or her head. Usually we will know what the patient's medical diagnosis is, and in any case, that's the physician's responsibility. But nurses diagnose the responses to people's healthcare condition. That's the nursing diagnosis. Most working nurses don't necessarily, they may think about nursing diagnosis, but they don't necessarily write out a formal care plan like you will in class. But they're operating with the nursing diagnosis in mind, and they may not express it in exactly correct NANDA terms, but they'll have a diagnosis in mind, and they'll be using it as they go along, but in an informal way. And part of the nurse's task, or one of the problems that nurses have, is time management. You can only be one place at one time. So who do you respond to first? Well, you'll have urgent situations where there's a possibility of a patient falling, say, if you don't respond right away, so you certainly have to respond right away to those. But then there will also be things that are very important to do, but they don't have to be done right this instant. And sometimes when you're so busy putting out fires, as they say, you may skip some of those things, and then an hour or two later it's like, oh, I really should have done that, I need to go do that. Like, for example, when you have patients that are about to fall, why, obviously you tend to those first, but don't neglect that patient that you need to turn. Maybe you don't need to turn them right this minute, but you do need to get in and turn them. And then there are other things that may not seem like a priority, but truly are, like documenting your care, for example. If you end up waiting till the end of the shift to document, your documentation's not going to be very good. So you also need to make time for that. Nurse roles in assessment and in a lot of things have expanded a great deal over the course of nursing history. Even over the course of my lifetime and my career, the nurse's role has expanded, and I expect that that will continue. By the time you're taking care of me, I'll be amazed at some of the things you're doing. The main factor, there are various factors that have driven this, but one of the main factors is technology, the growth of technology. And by that, 100 years ago, there was no way to monitor patients continuously like there is today. Now we can see in real time, we can see what the vital signs are doing. We can see the electrocardiogram, which gives us insight into what's going on in the patient's heart, the electrical system. We can even see images of the heart with ultrasound. We can get 12 lead EKGs in a matter of minutes and look at them. And when these technologies developed, why, it begs the question of, well, we can get all this information in a quick amount of time, but it's no longer sufficient to collect our data. The doctor makes a round once a day, and the doctor's going to assess it all. We need somebody that's on the spot that can evaluate this information, assess it, and determine what to do. And so that has led to a great expansion of the nurse's role. 100 years ago, their CPR was not known, or it was just CPR began to develop in the 1950s, really. And even at first, it wasn't all that successful. It has been refined over the years. ICUs were unknown. All of these things. So people, of course, a lot of people died that now they would not die. But at the time, it seemed like, well, it's sufficient to just let the doctor make the round once a day, and that's all that the patients need. Meanwhile, the nurses put into place what is the orders, and they, take care of things. If something changes drastically, they'll call the doctor maybe, and that seemed sufficient. But as the speed of information, as what you can do with that information has increased, why, that no longer is sufficient, and I don't expect that trend to stop anytime soon. So as you're working as a nurse, you'll have various patients, and they'll be at all kinds of different stages in the assessment process. Like, you may have a patient you go in to see for the first time, and you'll be doing basic assessment on them. You're not even sure what they're there for. You got your report maybe from the nurse, the previous nurse, but you're not really clear on what stage of their hospital stay. So you just go in and talk with them a little bit, and maybe do some assessment and try and get a handle, and you learn that they're in for abdominal pain, that the doctor has not come up with a definite diagnosis yet. They're waiting for some tests still, more tests. And then while you're in there, you get a call from the nursing assessment. You better come look at Mrs. Jones in here. I think she's doing worse. And so you go in there, and you find that she looks, she's hypoxic, and you had already done an assessment on her, and you had even gotten to planning and implementation. You had put her on the non-rebreathing mask, and so you're at the evaluation stage here, and you say, well, okay, this intervention I did is not adequate. I need to escalate this. She probably needs to go to ICU, because you have assessed her. She's at, you know that she has decreased reserve in her lungs, and that she's in the process of dying, but you want to, put that off as much as you can. And you can say, well, she's going to need more than we can give her here on the floor. We're already giving her. The only other thing we might try would be BiPAP or something, but she probably realistically needs to go to the ICU. So I think I'm going to call a rapid response, or I'm going to call the physician and see if we can move her, or whatever you're going to do. And so you do that, and then there's somebody else that maybe meanwhile you haven't forgotten that first patient, and so you take even as you're taking care of that, while you're mentally processing some of the assessment findings for that first patient, you do your nursing diagnosis and start thinking, okay, what interventions am I going to do for my first patient there? So you'll be constantly, it's almost like juggling. You'll be juggling various patients who are at various stages of the nursing process. And the nursing process itself is not this smooth little circle that it shows it in the book, because there will be things where you'll be in the middle of the assessment and you'll already know what the diagnosis is, or maybe you'll have a diagnosis but then you realize later that no, that diagnosis actually was wrong, because you evaluate maybe and you say, oh, that initial diagnosis was wrong. I think we need to go back and try this other diagnosis, which leads to a different plan and different implementation. So you're kind of jumping back and forth among various stages, and you're jumping back and forth among various patients as well. And you'll probably be doing various types of assessment each shift you work. Like, you get a new patient in and do that initial comprehensive assessment, but then you're also doing the ongoing partial assessments on the rest of your patients. And then that nursing assistant calls you to the room when somebody's having an emergency. You do an emergency assessment, and the focused one comes in when you have your abdominal pain patient calls you to the room and says, oh, by the way, I've had this cough for the last 2 days. So that is when you'll do a focused or problem-oriented assessment. They're not there for cough, but it's a new symptom that they have, and you want to assess what's going on there and what are we going to do about it. Again, these steps are not necessarily, you may jump back and forth between them. You may, for example, subjective is any data the patient tells you, where objective is data you get with one of your senses. And either one of those could require validation. Why would a subjective data need validation? Well, maybe the patient's telling you different things at different times, or maybe what they're telling you doesn't correlate with what you're seeing. Say you have a 5-year-old patient, and he tells you, oh, I haven't eaten in 3 days. I haven't eaten in a long time. And you might ask the mother, oh, what's this that he hasn't eaten in 3 days? That seems a little odd. And, well, yes, that's true. He hasn't been able to eat. So that would be one way of validation. Another validation might be required for an objective assessment when, for example, say the blood pressure you get doesn't go along with the way the patient looks. Like, you might get a blood pressure of 80 over 50, but which is a little alarming, and you say, well, how do you feel? And the patient says, oh, I feel fine. I feel okay, no problem. You're not weak? No. Not dizzy? No. Well, that maybe your technique is not good, or maybe the blood pressure cuff was too big, or various things. And then never forget to document, because various reasons. That's really the only evidence you're going to have if your care is questioned. Your documentation is going to be the only evidence you have of the care. And if you don't document in a timely manner, why, your documentation's not going to be very good. Interview techniques. So it helps whenever you're interacting with patients or relatives, or even if you're down in the lobby where you might be seen, think of yourself as being on stage. Because if you're down in the lobby and you're telling your friend, oh yeah, I went out and got drunk last night and I was so, this and that, and then you don't know who's watching and listening. Maybe the relatives are coming by and that nurse is really a disgusting person, and then they get up to the floor and you are their relative's nurse, and that doesn't give a good impression. And once you make a bad impression, or once you damage a nurse patient relationship, it's really hard to fix it. And it can haunt you for years, because some of these patients keep coming back and back and back, and maybe 6 months from now that patient comes back, you go in to take care of her, and she puts on the call light, I don't want this nurse, I want somebody else. So pay attention to all of the facilitators and the barriers that are mentioned, and try to make your communication and your way of the way the impression you make. Now, we don't want you to be constantly thinking of yourself. In fact, we actually want you to eventually be constantly thinking of the patient and focused on the patient. But you should develop a certain control over the way you come across. Be self-aware of the way people are going to perceive how you come across. And I think if you have worked in the service industries, such as in retail, as a restaurant, or different service type industries, that will give you a heads up on how to do this. Those of you that never have, if all you've ever done is working in a back office somewhere, and you could, then you're going to have to struggle with this a little more. Those of you that have some experience working in service will certainly have an advantage and bring all those kind of skills to work with you in nursing. We've already talked about the language issues, and that you don't want to use family members to interpret. You can use them for things that are low stakes, like, what do you want for breakfast or something. You can get the family, but if you are going to be doing formal assessment, you want a medical interpreter. And when you get one, you probably want to get the most information for your call, and try to get everything you can think of covered in that call, because you don't want to be calling in a half hour. Now, if you do a half hour later, something else comes up, certainly make the call, but you want to try and get the most information you can each time you call the interpreter. Usually, by the time the patient first comes up to the floor, we already have the biographical data. The admission clerk got that. All you need to do is validate it. And you can focus in first thing on reason for seeking care. That's what the patient wants to talk about, so that will be a natural place to start. And you'll do cold spa not only on the history of present concern, but on each of their symptoms they have. And then you'll also want to get the past history, both for them and the family. Review of systems. Remember, that is where, say they came in for abdominal pain, well, you start asking about, well, have you had, and you list various things they might have had, like, have you had any dizziness, any pain and headache, any eye pain, maybe do head to toe type order. And so they didn't come in for any of those things, but maybe they had a cough, say, and you may catch that where you wouldn't otherwise by asking about it. And then finally, after you've hopefully built some trust, then we're going to ask about lifestyle, health practices, those kind of things. The questions that may be a little more sensitive, a little more embarrassing, and all that. And hopefully by then you have built some trust. Vital signs. This is probably your most high yield information. I mean, for a quick thing to do, it probably gives you more information than most of the things you do. And as we'll see, the temperature, pulse, respiration, blood pressure, all of these things are interrelated, where if one goes up, it's going to affect the other. If one goes down, it'll affect the other too. And when we look at them, we also want to be sure to look at them in terms of where the patient has been, both their previous vital signs and what they're doing right now. So when let's say you have a patient whose blood pressure is 80/50. Well, as we said earlier, you're going to want to look at, is the patient doing okay otherwise or not? That's one thing to look at. Like, are they having any symptoms that would go along with that? And then you think about what could be causing this, and there are a lot of different things that could cause it. It could be that their heart rate is just, it could be driven by heart rate, a low bradycardia, where there's a low heart rate. Or it could be that they had vascular collapse. Those are very different reasons, and they're going to have different treatments. So blood pressure, all of these things, cardiac output, vascular resistance, blood volume, viscosity, or that is the thickness of the blood, and elasticity of blood vessel walls, those are all going to affect the blood pressure in different ways. Another one is pulse. Say your patient suddenly goes up to 140 heart rate. Well, it could be atrial fibrillation. It could be just a sinus tachycardia as a result of blood loss, in response to blood loss. It could be tachycardia caused by exertion, such as the patient that has COPD, gets out of breath when they walk a short distance. And again, there are going to be different responses by the nurse called for each of those situations. It could be because they're running a high fever. They just started running a fever. That's where you want to look at not only the pulse, but how is it related to those other vital signs, and how is it related to what they're doing. Also check, is the heart rate regular? Is it weak, thready, or is it strong? And respiration. Again, this one is probably the most sensitive vital sign to changes. Like, before you see anything in the pulse or blood pressure, you're likely to see it changes in the respiration. And when you see changes, you also want to assess, is the oxygenation adequate or not? And you could check for hypoxia by looking for nail bed refill, capillary refill. You could look for a pulse oximeter, various things like that. Temperature. We have various methods, and each method will either be a little lower or a little higher than the core body temperature. You need to know how each method relates to the core temperature, and also how they relate to the daily pattern. So thank you for viewing this module. I'll see you in the next one.